We described the influenza life cycle and the mechanism of action of endonuclease and neuraminidase inhibitors. We distinguished between influenza and other acute respiratory illnesses, and given a patient with acute influenza, we designed a therapeutic regimen. Now, list the likely causative pathogens for rhinosinusitis and pharyngitis, including susceptibility profiles and patient risk factors for multidrug-resistant pathogens. Now, majority of cases of rhinosinusitis are due to viral causes. So acute viral rhinosinusitis is due to various viruses, which we typically don't treat, with the exception of influenza for most patients. Now, a small portion of these, about 2% of adult cases, are bacterial rhinosinusitis, and these are due to respiratory bacteria, so respiratory pathogens. So then, the top of the list is Streptococcus pneumoniae. There's also Haemophilus influenzae, Streptococcus pyogenes, and Moraxella catarrhalis. So if we are to treat acute bacterial rhinosinusitis, these are the 4 organisms that we want to target. So we want to make sure we have agents that work well against these. Now, potentially Staphylococcus aureus could cause rhinosinusitis. However, it's rare, and MRSA coverage is not recommended. So we do not want to cover empirically for MRSA. Now, for acute pharyngitis, of course, it could be due to different causes, mostly due to viruses, but also occasionally some other bacteria will cause pharyngitis. The IDSA guidelines are specifically for Streptococcus pyogenes or group A strep pharyngitis. And the way we diagnose it is that we do a throat swab, and if the patient tests positive for strep pyogenes, that's when we treat it. So the treatment is primarily targeted at Streptococcus pyogenes. Now, since we are talking about Streptococcus for the most part, especially for rhinosinusitis, is strep pneumo, so we should keep in mind risk factors for drug-resistant strep pneumo. For the most part, these are similar to the risk factors for drug-resistant strep pneumo from the IDSA guidelines for community-acquired pneumonia. The 2012 guidelines are more recent, so their risk factors have been updated, so they're slightly different than what the community-acquired pneumonia guidelines had. So age over 65 still remains a risk factor. Recent hospitalization, meaning the previous 5 days, is also a risk factor for drug-resistant strep pneumo. So is antibiotic use in the last month. People from geographic regions where there is a more than 10% risk of penicillin non-susceptible strep pneumo. People with severe infections, and the way you decide if an infection is severe, if someone has a high fever of 39 degrees centigrade or higher, or if there is a threat of suppurative complications, and exposure to children in daycare center, and of course immunosuppressed patients. So these patients will be at risk of drug-resistant strep pneumo, so that we should keep that in mind when we choose treatment for acute bacterial rhinosinusitis for these patients. So when it comes to, so if someone does not have risk factor for drug-resistant strep pneumo, you can use, drugs that have activity for strep pneumo. So basically all of these agents, with the exception of ciprofloxacin. So ciprofloxacin is not good for any Streptococcus pneumonia, so that's why it's not a respiratory fluoroquinolone, so that should not be used. Pretty much any other agent that's listed here is good for strep pneumo in the absence of risk factor for drug-resistant strep pneumo. If there is risk factor for drug-resistant strep pneumo, penicillin and amoxicillin will likely be not working. One thing that we can do with amoxicillin, if you use a higher dose of amoxicillin, it could overcome that resistance. So if we use the same is true with amoxicillin clavulanate. So if you use a higher dose of it, you can actually overcome the resistance from strep pneumo. But pretty much first, second, and third generation oral cephalosporins do not have good activity against drug-resistant strep pneumo. The same with trimethoprim sulfamethoxazole. It's not good against drug-resistant strep pneumo. And as if macrolides and tetracyclines also do not have good activity against drug-resistant strep pneumo. Now for rhinosinusitis, we should also keep in mind that Haemophilus influenzae and Moraxella catarrhalis can also cause these. And when it comes to that, if you suspect these, then amoxicillin clavulanate will be the best option, because these two organisms are likely to produce beta-lactamases. So that beta-lactamase will break down penicillin, the beta-lactamase will break down amoxicillin, but clavulanate will block, or I should say inhibit, beta-lactamase. So therefore, even though these organisms are likely to make beta-lactamases, clavulanate will inhibit it, so amoxicillin clavulanate will have activity against it. Now those beta-lactamases will also break down first generation cephalosporins, but second and third generation cephalosporins are stable against those beta-lactamases. So second and third generation will actually have good activity. Trimethoprim sulfamethoxazole does not have reliable activity against Haemophilus influenzae, so we should keep that in mind. Clindamycin doesn't have activity against any gram negatives, so we should keep that in mind. And when it comes to atypical coverage, you should note that only fluoroquinolones, macrolides, and tetracyclines have activity against atypicals. The rest of them do not.